Hey everybody, I'm Jennie Womack, and for our Snip-it presentation, I chose Pediatric Osteoporosis. This presentation is in partial fulfillment of N5318, Advanced Pharmacology with Dr. Grande. So the disease process that I chose for our Snip-it assignment is pediatric osteoporosis. Typically, we think of osteoporosis as being a postmenopausal women's disease, but pediatric patients can also have osteoporosis as a diagnosis. Adults are typically diagnosed when they lose net bone mass density after they've had a chance to reach the peak age of accrual. But children, they aren't as old, so they have not had time to reach the peak age of accrual, so their diagnosis is based on actual bone loss or inadequate bone size. Most children that have osteoporosis have it secondary to some other chronic issue. These issues are usually inherited. An example of one of these disorders would be osteogenesis imperfecta. After reviewing the literature, it seems that there are three main reasons for pediatric osteoporosis. The first reason would be a deficiency in calcium, phosphate, or vitamin D, which causes the bones not to accrue normally. Example of someone with this might be a premature infant. A second reason for osteoporosis would be bone loss from trauma or infection due to immobilization of the bone, the stress response in the body, and eventual bone reabsorption. Lastly, a third reason would be inflammatory responses that increase bone reabsorption via stimulation of osteoclastic cells. The two main focuses when deciding on correct pharmacological courses would be the medical management of high bone reabsorption and medical management of low bone formation. The drug of choice for osteoporosis is biphosphonate. This drug acts as an anti-reabsorptive agent in the bones. Ibandronate, racindronate, and zoldronic are just a few of the actual drug names in this category. Biphosphonate works, its mode of action relates to its ability to decrease osteoclastic bone reabsorption by increasing the rate at which osteoclastic cells die. This drug also decreases the reabsorption of these cells back into the body, which prevents further bone loss. The expected outcomes are good. In children, this drug dramatically has been shown to increase bone mineral density, strengthen vertebrae, increase grip strength, increase height, decrease bone pain, and decrease fracture rates. It is considered safe and effective for the use in pediatric patients. This medication is usually given orally to adults, but much of the literature I found said it's commonly given IV in children. The cost of this drug is very reasonable. Consumer Reports list the oral version at anywhere from $39 to $63 a month depending on the amount or dose prescribed. I couldn't really find anything on the IV form, the cost when I searched, but I'm sure it has the typical hospital markup. Another drug discussed in our text for osteoporosis was human parathyroid hormones. Teriparatide was approved to help aid in bone formation by the FDA. Its mode of action occurs as it promotes osteoblasts to activate, which eventually stimulates actual bone growth. The safety and efficacy of parathyroid hormones have not been evaluated for more than 2 years according to our text. There was not a lot of information about the use of human parathyroid hormones in children. One article I found mentioned repeated injections are needed and it's quite expensive. Another article I found also mentioned that this drug is not approved for pediatric patients due to the incidence of cancer in lab rats, which is kind of scary. So ultimately, the biphosphonate is the drug of choice when a child is diagnosed with pediatric osteoporosis. Just in conclusion, ultimately, the plan of action for children diagnosed with pediatric osteoporosis is first physical therapy, second an enriched diet, third increase in calcium and vitamin D, and the use of biphosphonates. So thank you for watching. I hope that this was informative, and good luck on your projects. Bye.